We are learning more about a new study saying breast cancer patients could avoid chemotherapy in certain cases. We are going to explain that in our Newsmaker segment that is coming up. 266,000. That is how many women are expected to be diagnosed with invasive breast cancer alone this year. Now, a new study published last week suggests that some of those women may be able to skip out on chemo altogether. So Dr. Erica Hamilton with the Sarah Cannon Research Center, Sarah Cannon Center, I should say, is here to talk about that.
Thanks for having me.
It's good to have you here because this is really kind of stunning in many ways.
It's very exciting.
Explain in more detail what this means.
Sure. So this was a study for early stage breast cancers that express the hormone receptors. So it's a subset of breast cancers. And it uses a test called Oncotype DX. We've had this test for a little bit over a decade now, and we've used it to make decisions about whether women with hormone receptor positive breast cancers need chemotherapy. We've known that if you're low on this test, you probably don't need chemotherapy, and if you're high, you do. We've been a little bit uncertain about what to do with the women who fell in the intermediate or the middle bucket. And so this study randomized 10,000 women volunteers, essentially the ones that ended up in that intermediate bucket, either to receive chemotherapy with endocrine therapy or a pill, or just the pill alone. And what it showed is for the vast majority of the women, they didn't need chemotherapy.
Which is pretty, so what does that mean in terms of numbers? How many people will not have to go? The chemotherapy is so hard on the body. We'll talk about this in a second, but how many people will not have to go through that?
That translates to about 60,000 women in the United States a year. So it's a significant proportion of women. So more women than not probably don't need chemotherapy that have hormone receptor positive, node-negative breast cancer. It doesn't apply to the other type of breast cancers like triple negative and HER2 positive, but it's a big proportion of women in America.
And I imagine not going through the chemotherapy is a benefit on its own, not putting the body through that. So it allows you to actually fight and use the therapy that you are conducting.
Exactly. No one wants to sign up for chemotherapy. They don't have to have it.
Right.
Certainly people tend to do well with it if they need it, and we can kind of help them through that period. But certainly, you know, women don't want it if they don't have to have it. And as oncologists, we don't want to have to give chemotherapy to those who don't need it. I think it's a push for what we call personalized medicine that we're really getting a whole lot better at figuring out which woman really needs which therapy and tailoring that recommendation to that specific person and her cancer.
I was over at Hope Lodge today and just in general talking to folks that are going through some of the cancer treatment, some of the chemotherapy, 6 to 8 week regimens. The advances that are coming out right now are cause for hope.
They are. I think it's great cause for hope. I think, you know, not only are the drugs, the medicines we give getting better, but figuring out when to use those particular medicines is a huge win across oncology.
And when you say early detection on the breast cancer, early stage, how does that classify? Where does someone have to be? So
in this particular study, it talked about women who didn't have lymph nodes involved in their cancer. So as we say, node negative. The majority of hormone receptor positive breast cancers we find are node negative. So this does apply to the majority of patients.
The Sarah Cannon Cancer Center, where do you guys stand as far as when women should be getting mammograms?
That's a great question. I personally stand with an individual discussion with your doctor, but I think you should begin discussing it at 40. It may be appropriate to do even earlier in people with particularly high risk factors like a BRCA1 or 2, the gene that causes breast cancer, right? In other patients, it may be worth waiting a little bit longer, but I think you should begin to start having that conversation with your doctor about whether mammograms are right for you at around 40.
And certainly if there's a family history, I guess you probably a little bit more.
Exactly. Normally the rule of thumb is you start 10 years before the index case of breast cancer in your family. For example, my mother had breast cancer at 43, so I would start at 33.
This headline, for most of us, and I'm sure you were waiting for it to come out, for most of us it kind of caught us off guard. It's amazing that this is being said right now. What's the next headline that you hope comes out in regards to treatment of breast cancer?
You're right. This study actually started in 2006. It's hard to imagine that.
Right.
But it is quite breaking news. I think some of the really exciting agents for breast cancer right now are probably immunotherapy. We're looking at that for a different class of breast cancer, triple negative breast cancers. We've seen a lot of really exciting news about immunotherapy in cancer such as lung and melanoma, and we're trying to figure out exactly how to best use that in breast cancer now as well.
Dr. Erica Hamilton, thank you so much.
Thanks so much for having me.
Sarah Cannon Cancer Center is a wonderful facility we have here. It brings so many people to our city for the finest treatment in the world. So it's good.
Thank you.
Appreciate it. All right, let's go to Jeff for the forecast.